Good day, everyone. I am Christine, the moderator for this webinar. I welcome everyone to today's webinar, that is CMS Hospital Restraint and Seclusion, Navigating the Most Problematic CMS Standards 2025. I would like to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon recently served as the Regional Director of Risk Management and Patient Safety for Kaiser Permanente, Colorado. Laura holds a Bachelor of Science degree from Regis University, UCEP of Denver, a Doctor of Jurisprudence degree from Drake University College of Law, Des Moines, Iowa, and a Registered Nurse Diploma from St. Luke's School of Professional Nursing, Cedar Rapids, Iowa. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you, Christine, and welcome everyone. We're talking about, as the title said, a very problematic standard within the CMS conditions of participation, and that's in restraint and seclusion. I always just start with a very brief introduction. First off, why are we here? Why is this program being presented? And that's so you don't get one of these. And that's that statement of deficiencies where you then have to do the plan of correction. So as I mentioned, they're now starting to rethink the use of our restraints, and especially for those in delirium. Well, that study found that they're used less often when you have more nurses on duty and more RNs present, the lower the use of the restraint. So why was that? And there was a more recent study back in 2022. I want to start just a brief overview of what we're talking about, the conditions of participation. And how this all starts is the regulation itself starts in the Federal Register. And then CMS has certain jobs. Number one, they have to send out notice to their surveyors in what's called a transmittal. Hey, this is the new regulation. The areas we're talking about today for the acute manual, right there, it's patient rights deficiencies. I talked about how bad that can be and why CMS is so really focused on this. Well, here's just an example of some of them. There's a couple slides here. On the complaint manual, there is a separate manual for complaints. So on death reporting, again, this is in the complaint manual. So once this comes in, the regional office will evaluate the report, find out, is there really a violation of the patient rights section? You have to report if the patient dies in restraint, and so there's a lot of much more information that's required under that particular form. So let's go ahead and start now with our conditions of participation. Again, Appendix A, multiple tag numbers, multiple pages. It is the largest section within your manual. And there are additional tags on training and death reporting. Again, I'm going to start with seclusion because there's only one tag number. The majority are restraints. It's an involuntary confinement, alone in a room or area. Remember that one patient was put in quote timeout, in quote, alone? Okay, that's seclusion, where they're physically prevented from leaving. What is not seclusion, there is some reference and some resources out there to reduce the use of seclusion. It's called Learning from Each Other. It has tools and forms. Let's talk restraint and seclusion. It's in the patient rights section. It's the largest section of the manual, and it applies to all hospitals, all locations in the hospital, so it doesn't have to be just behavioral health, and all patients. All patients have a right to be free from unnecessary physical or mental abuse and corporal punishment, especially unnecessary punishment. To do this, we have to start with a comprehensive assessment. So there could be multiple reasons why you want to put a patient in restraints. They are responsible overall to have this culture that supports a patient's right to be free from those unnecessary restraint and seclusion. Here's just some of the minimal factors that we need to look at. The minimum, staff have to document. Now this is in the application of restraint or seclusion. Now there are certain things that are not covered by this law, by this rule. I also want to see incident reports, and especially with restraint and seclusion. Take the definitions that CMS has in their regulations. So that's a physical restraint. Then we have our medical, or chemical, or drug. They give us criteria for these medications. So it's appropriate when they can help them function more appropriately in the world. What is not appropriate? It's not, in other words, it's not okay. You can't use this. So they also provide us with what is not a restraint, what is not considered a restraint. Hand mitts. Here it becomes a little bit fine line. And then other devices or practices that might be seen as a restraint, other things that are included, and then age-specific ones. Like we have to be least restrictive. And especially, it doesn't matter if restraint or seclusion. We have to include restraints in the use, in the written plan of care. So we always have to use, of course, safe and appropriate techniques in applying restraints and seclusion. So in addition to the plan of care and our assessment, we have to have an order. This is the top-sided deficiency, by the way. Protocols, standing orders, or PRN orders. We have to tell the attending as soon as possible, or at least consult them There are also time-limited orders. So what do you need to know? These are maximum time limits. They have to document their findings to support continued use. Provider, trained staff, they have to do that ongoing monitoring and assessment. CMS doesn't specify the time frame for the assessment. So what should your policy include? There are certain things you do have to document. Their mental status, of course. How's their behavior? And that could be the type of restraint that give them some suggestions and help them. Here's just some other suggestions. So back to the regulations. The 1 hour rule. Boy, did this cause troubles when it came out. So it can be done by someone who is specially trained. Of course, your physician or advanced practice provider. What do you want to include in the evaluation? If an RN is the one who does that 1 hour face-to-face, then they have to consult with the provider as soon as possible. If they're restrained alone in a room, and of course our ever-present documentation we still have to do, that 1 hour face-to-face. So here's the staff training that must occur. So they must be trained and demonstrate competency. All staff who have direct contact with the patient. Yearly education, annual skills lab, good place to do it. But here is what they have to evaluate. This is what the training must include. So here's what has to be in that training. So staff have to include non-physical intervention skills. They even give some triggers or examples of triggers. And of course, have education on the safe application. Identification of behavioral changes have to be included. Now, death reporting. You must report any death associated with the use of restraint or seclusion. And here's reasonable to assume and just some of the documentation. If it's those soft wrist restraints, no seclusion. So as I get close here, here's just some suggestions. Add a statement to the patient rights if you already don't have it there. Educate everyone so they understand what are their responsibilities, limitations, and here's the state law and CMS standards. Staff should be well trained on restraints and seclusion. I do want to just show you some of the resources. There's about 17 pages. I tried to include those specific forms that I did mention and a couple other templates for you if that's what you want to look at. So I want to thank everyone for participating. So thank you everyone for attending. And Christine, I'll give it to you to close us out. Well, thanks again for everyone who did participate. Behavioral health is a very tough area. And I commend those of you who work in behavioral health because it is very challenging. You don't have a drug test that you can run or a lab test that says what's going on. You really have to use everything in order to help the patients and assess them and take care of them. So thank you very much, and thank you, Christine.
Thank you, Laura. That concludes the session for today. Thank you everyone for participating. You may all disconnect now and have a productive day.